Bismillahirrahmanirrahim. Today we're going to have another lecture in pharmaceutical technology, which is about suppository dosage form. The objectives of this lecture will be to learn what does it mean suppository, to be familiar with the types of suppository, the advantages and disadvantages of suppository dosage form, and we're going to talk about the factors that affect the rectal absorption of therapeutic agents. And then we're going to move on into the formulation of this dosage form. We're going to talk about the bases that are used in the formulation, method of preparations, and calculation of the mass of base required. And then we're going to end it up with some problems in suppository formulations. Suppositories are solid bodies of various weights and shapes. This dosage form is adapted for introduction or insertion into the body orifice, such as rectum, vagina, urethra. They are usually melt or soften or dissolve at body temperature. Suppository may act as a protectant or palliative by itself to the local tissues, or it might act as a carrier of therapeutic agent for systemic or local effect. Regarding morphology, suppositories are tapered at one end. This will aid insertion into the body orifice, and then frequently wider at the middle, and then tapered again toward the end. This tapering towards the end will help retention in the rectum and enabling the suppository to be pressed forward by the anal sphincter. The drug concentration or the active ingredients concentration in the suppository may range from 0.1 to 40% weight per weight. In general, suppositories are composed of inert base into which the therapeutic agent is loaded, dissolved or dispersed. Types of suppositories. The most commonly used and available one is rectal suppositories. They are meant for introduction into the rectum for either local or systemic effect. They are generally available in different sizes and shapes to meet the needs for infant, children, and adults. They are usually in a weight range between 1 to 2 grams, and their shape is either a cone or bullet shaped. The other type of suppositories is the vaginal ones. These are meant for introduction into the vagina. These suppositories are also known as pessaries. They are larger than rectal suppositories. Their shape is either conical, round, or wedge-shaped, and their weight is either 4 to 8 grams. They are mainly used for local action on the vagina. Vaginal tablets and vaginal capsules are nowadays available, which has substituted the vaginal suppositories. Usually, vaginal suppositories are provided with applicator to make it easier to introduce the suppositories into the vagina. Other types of suppositories include nasal, urethral, and ear suppositories. These are very rarely used and nowadays substituted by other dosage forms which are more convenient for use. This table shows the different sizes of different types of suppositories, and you can see the 0 is intended for children, 1, 2, 3, which are bigger, are intended for rectal use. The biggest one is the pessary, this one, number 4. A and B is, you can see it's thin and cylindrical in shape, is intended for nasal and urethral use, and it's called nasal and urethral bougies. Advantages or uses of suppository dosage form. Rectal dosage form can be used to provide a local effect for the treatment of infection and/or inflammation. These inflammatory cases include hemorrhoids, proctitis, Crohn's disease, and ulcerative colitis. It's also used to promote evacuation of the bowel. This is done by inducing irritation to the rectum. Evacuation is important to relieve constipation or to clean the bowel prior to surgery. Suppository dosage form also provide an ease performance by the patient, especially following proper advice from the pharmacist. In addition to the local effect, rectal dosage forms can be used to provide systemic effect. This is important in situations where oral drug absorption is not recommended. These include patients who are unconscious, example in intensive care unit or post-operative patients. Patients who are vomiting with gastrointestinal infection or migraine or other cases. Rectal dosage forms are also recommended for medicines or drugs that are gastroirritant, such as non-steroidal anti-inflammatory drugs. This is especially important in chronic use. Rectal dosage forms are also recommended for drugs that are prone to degradation in the stomach. These medicines might be affected by the low pH of the stomach or the enzymes of the stomach. So it's better to use it rectally rather than orally. It's also recommended for medicine that are radically absorbed from the upper gastrointestinal tract. For drugs that are extensively first pass metabolized, it's better to use them rectally rather than orally. Therapeutic agent from the rectal dosage form can be absorbed directly into the systemic circulation. Therefore, avoid direct entry into the liver. Rectal dosage form is also recommended in case of faster onset of action is required, especially when the medication passes directly into the venous circulation, so there was no metabolism in the liver. This will offer faster onset of action. It should be noted that all the medicines that can be absorbed following oral administration can be systemically absorbed when taken rectally. Although suppository dosage form provide a number of advantages, there are still a number of disadvantages. These include, number one, unpopularity, especially in countries like America and UK. The use of rectal dosage form for systemic administration is not common. However, in Europe, the opposite is true. Number two, the use of suppository dosage form required specialist advice from the pharmacist of how to use it. Some people don't know how to use it. Some of them take it orally if they didn't get enough advice, and some of them don't know how far they should insert the suppository into the body orifice. All of these required pharmacist advice to the patient. The other drawback is the absorption of the therapeutic agent from the rectum is slow and prone to large intra and intersubject variability. The presence of feces or stool in the rectum will affect the rate and extent of drug absorption. Rectal administration of the medicine also may result in the development of side effects, which is local, such as proctitis. Industrial manufacture of suppositories is more difficult and more sophisticated than other common dosage forms. Suppository dosage form required special storage, and improper storage may lead to deformation of the original shape. We mentioned that suppository dosage form can be used for local and systemic effect. This depends on the nature of the medicine, the concentration, the rate of the absorption, and the type of base that is used to prepare the suppositories. Examples of the classes of the medicines that are administered by rectal route for systemic absorption include antiemetics such as prochlorperazine, analgesics such as oxymorphone hydrochloride, anti-inflammatory agents such as indomethacin, ergot alkaloids, sedative and antispasmodic medicine. Examples of the classes of drugs that are administered by rectal route for local absorption include emollients, astringents, antibacterial, and local anesthetic agents. The process by which medicines are absorbed into the systemic circulation involves first the dissolution of the drug in the rectal fluids. This is often preceded by the dissolution melting of the dosage form to release the active ingredient. This followed by diffusion of the drug through the rectal fluids to the rectal mucosa, and then absorption takes place. There are a number of factors that affect the rate and extent of drug absorption. These include first, the site of absorption within the rectum. From the anatomy of the rectum, we know that there are three rectal hemorrhoidal veins. These are the superior rectal veins, the middle rectal vein, and the inferior rectal veins. Following absorption from the rectum, the therapeutic agent enters the hemorrhoidal, one of these rectal veins. Blood from the superior rectal vein enters the portal vein, which flows into the liver, where first pass metabolism of the drug takes place. Conversely, blood in the middle rectal vein and the inferior rectal vein goes directly into the general circulation. The site of absorption will affect the fate of the therapeutic agent within the bloodstream. So if absorption takes place through the superior rectal vein, then it's going to go to the liver where metabolism takes place, while if absorption happens through the middle and inferior rectal vein, then the medicine will go directly to the systemic circulation. Therefore, the metabolism of therapeutic agents will depend on the location of the dosage form in the rectum. It should be noted that it is difficult to ensure that the drug absorption occurs exclusively through the inferior and middle rectal veins. Therefore, first pass metabolism of therapeutic agent might occur following rectal administration. The other factor that affects the rectal absorption of the therapeutic agents from the suppository dosage form is the partition coefficient and the degree of ionization of the therapeutic agent. If we have a lipophilic rectal product and the therapeutic agent is lipophilic as well, this will result in a slow release of the drug, and the solubility of the drug in the rectal fluid will be low. Conversely, the use of dispersed hydrophilic drugs in lipophilic bases result in greater thermodynamic tendency to dissolve in the rectal fluid. This combination is preferred over the first one. It should be noted that the limited volume of fluid in the rectum will affect the rate and extent of drug dissolution. Therefore, increasing the drug load in the suppositories will not enhance the drug absorption. If we know that the absorption requires the presence of the unionized form of the drug, then the degree of ionization of the therapeutic agents will affect the resultant absorption by the biological membranes of the tissue where the dosage form is introduced to. Generally speaking, pH and buffer capacity of the biological fluids will control the degree of ionization and consequently will affect the absorption of the therapeutic agent. Regarding rectal fluid, it has poor buffer capacity. This will result in the inability of this fluid to control the pH and hence the ionization of the active ingredient. Therefore, the salt form of the therapeutic agent effectively controls the degree of ionization. The other factor that affects the rectal absorption is the particle size of the dispersed active ingredient. Suppose you have an active ingredient that has been dispersed in the appropriate formulation base, such as hydrophilic drug dispersed in a lipophilic base, and we mentioned that this is the best or the preferred combination. Then the rate of dissolution of the drug is inversely proportional to the particle size of the dispersed active agent. So the larger particle size, the slower rate of dissolution, and vice versa. The physicochemical properties of the formulation base can also affect rectal absorption of the therapeutic agent. One of the main criteria for rectal formulations is the ability to release the drug. An interaction between the formulation and the dosage form will result in a delay release and therefore will affect the local action or the absorption. This interaction could be specific, resulting from specific interaction between the drug and the vehicle or the base. It could be non-specific, in which lipophilic drugs are dissolved in lipophilic bases. This concern can be avoided by choosing drug salt. It is important also to ensure that the formulation is not irritant to the rectal mucosa, because irritation can cause or result in defecation and therefore result in the removal of the dosage form before the required concentration of the drug to be released. This table shows the non-specific interaction between the active ingredient and the base and the effect in drug release rate from the dosage form. So if we have oily soluble drug incorporated into oily base, this will result in slow release and poor escaping tendency from the dosage form. If we have water-soluble drug with oily base, this will result in a rapid release of the drug or the active ingredient from the dosage form. If we have oily soluble drug with water-miscible base, this will result in a moderate release rate, and the same happens if we have water-soluble drug in water-miscible base. So definitely from here we can conclude that water-soluble drug in an oily base is the preferred combination. Suppository bases. There are a number of key properties that an ideal suppository base should have. These are: number one, the base should be solid at the storage temperature of the formulation, but should soften, melt, or dissolve in the rectal fluid following insertion into the rectum. Thereby, it can release the active ingredient. Number two, the base should be non-irritant to the rectal mucosa and non-toxic, and we discussed why it shouldn't be irritant. Number three, the base should not chemically interact with the active ingredient. The base should be chemically and physically stable over the period of storage to provide a long shelf life. It should solidify rapidly to minimize the sedimentation of the dispersed drug. It should also release any medicament or active ingredients readily, easily to be molded and removed from the mold, and easy to handle. And finally, should be stable to heating above the melting point. Classification of suppository bases. There are two main categories of suppository bases. The first one is the fatty oleaginous bases, and the second one is the water-miscible bases. There's also a third subcategory, miscellaneous bases, that consist of lipophilic and hydrophilic excipients, and so shares properties common to the fatty and the water-miscible bases. Talking about fatty oleaginous bases, There are a number of natural, synthetic, and semi-synthetic fatty bases. First natural one is cocoa butter or theobroma oil. This is natural material, consists of a mixture of fatty acid esters of glycerol, stearic, palmitic, and oleic, predominantly in the form of triesters such as glyceryl tripalmitate. It has a number of advantages. These include a melting point range of 30 to 36 degrees centigrade, so it is solid at room temperature but melts in the body. It is readily melted on warming and rapid setting on cooling, miscible with many ingredients. It is safe, non-toxic, and non-irritant. When irritation or inflammation is to be relieved, then cocoa butter appears to be the superior choice because it has emollient and soothing spreading effects. Theobroma oil base has a number of disadvantages. This includes the polymorphism. When this base melted and cooled, it solidifies in different crystalline forms. This will depend on the temperature of melting, the rate of cooling, and the size of the mass. This polymorphism is due to the high content of triglycerides. So if the base is melted at not more than 36 degrees centigrade and slowly cooled down, it forms the stable beta crystals with normal melting point. However, if overheated then cooled down, it will produce unstable gamma crystals, which melts at about 15 degrees centigrade, or produce alpha crystals, which melt at 20 degrees centigrade. This problem can be overcome by slowly melting the cocoa butter over a warm water bath to avoid the formation of the unstable crystalline form. Theobroma oil has also the problem of adherence to the mold, and this can be solved by adding lubricant that is immiscible with the base. The softening point of the base is too low for hot climates. The melting point of the base can be reduced by soluble ingredients such as phenol or chloral hydrate. This can be solved by adding solidifying agents like beeswax at 4%. Rancidity on storage also a problem with theobroma oil. The base has poor water absorbing ability, and this can be improved by adding emulsifying agents. Leakage from the body and the cost are also disadvantages of the base. The other type of oleaginous bases is the semi-synthetic or synthetic triglycerides. The main problems associated with cocoa butter, such as polymorphism and variation in the composition, led to the development and use of suppository bases that are based on synthetic semi-synthetic glycerides. Typically, these systems are composed of mixtures of triglycerides, of higher saturated fatty acids, and dimonoglycerides. Examples: suppository and white suppositories. The advantages of the semi-synthetic synthetic triglycerides include: number one, their solidifying points are unaffected by overheating. They have good resistance to oxidation because of the lower content of the unsaturated fatty acids. The difference between melting and setting points is small. Therefore, they set quickly, and the risk of sedimentation of the suspended ingredients is low. They are marketed in a series of grades with different melting point ranges, which can be chosen to suit particular products and climate conditions. They contain a proportion of water in oil emulsifying agents, and therefore their water absorbing capacities are good. No lubricant is necessary because they contract significantly on cooling. These bases have a few disadvantages, which is they are brittle if cooled rapidly, so avoid refrigeration during preparation. The melted fats are less viscous than the theobroma oil, therefore this results in a greater risk of drug particles to sediment during preparation, and the lack of uniform drug distribution will give localized irritancy. To choose among the synthetic semi-synthetic bases for the use in the formulation of suppositories, there are a number of factors to be considered. These include hydroxyl number. The use of bases exhibiting high hydroxyl numbers should be reserved for the therapeutic agents that exhibit low reactivity towards this group. It should be noted that as the hydroxyl number of the base increases, this will increase the hydrophilicity. Consequently, this will affect the drug release and subsequent absorption of the active ingredients. The other factor is the melting properties. Low melting bases with a melting point less than 37 degrees centigrade are generally used for the formulation of suppositories when the systemic absorption of the therapeutic agent is required. However, bases of higher melting points are frequently used in the formulation of suppositories with local effect. The other factor that needs to be considered is the viscosity of the melted base. The viscosity of the base affects the mixing of the drug with the molten base, the flow of the molten dispersion into the molds, and the spreading of the formulation on the rectal mucosa and subsequent drug release. So bases with high viscosity will exhibit poor spreading properties and slow rates of drug release when compared to bases of low melt viscosity. The dispersion of solid drug particles into the molten base will dramatically affect the viscosity of the product. Therefore, in selecting a suppository base, the viscosity of the molten base is a major consideration. The other class of the suppository base is the water-miscible bases. There are two main categories or subclasses of suppository base in this classification. These are the glycerogelatin base, which dissolves in the rectal fluids, and the water-miscible bases, which are composed of polyethylene glycols. Glycerogelatin base can be prepared by dissolving gelatin 20% with glycerol 70% with the aid of heating at 100 degrees centigrade. The active ingredient is dissolved or dispersed in the aqueous phase 10% and then combined with the glycerol phase with stirring before adding to the mold. Alternatively, the gelatin may be dissolved in the heated aqueous phase, into which the active ingredient is dispersed or dissolved and then added to the heated glycerol. The mechanical properties of the formed suppository may be manipulated or controlled by increasing or decreasing the mass of the added gelatin. So the concentration of the gelatin is the key factor controlling the mechanical properties of the suppository. So for example, if you have an increased mass of the aqueous phase in the suppository, this will result in a soft suppositories, and this leading to potential problems regarding the insertion into the body. This problem can be solved by increasing the concentration of gelatin to control this. For example, in gelato glycerol suppositories, British Pharmacopoeia, the concentration of the gelatin is 32.5% weight per weight instead of 20%. In urethral suppositories, the ratio of gelatin to glycerol and water is 3 to 1 to 1. So the concentration of gelatin is 3 times that of glycerol and water. This will enhance the mechanical properties and facilitate the insertion of the urethral suppositories into the urethra. Because of the presence of water in this dosage form, it is important to include preservatives. For example, mixtures of methyl and propyl hydroxy parahydroxy benzoic acid. Total concentrations 0.2% weight per weight. These preservatives should be added to the aqueous phase during the manufacturing of the suppositories. Disadvantages of glycerogelatin base. Number 1. An associated physiological effect. Glycerogelatin suppositories will induce defecation. Indeed, this property is used to relieve constipation or to prepare the bowel before surgery. Number 2, difficult to manufacture. Suppositories prepared using glycerogelatin bases are more difficult to manufacture than other types. Number 3, hygroscopicity. Glycerogelatin bases will absorb moisture from the atmosphere. Therefore, it requires special packaging to prevent moisture uptake and ultimately to maintain the shape and the mechanical properties of the suppository. The ability of glycerogelatin bases to absorb water can occur also within the rectum. This will lead to dehydration and irritation of the rectal mucosa. And by this way, this base will induce evacuation of the bowel or induce defecation. To minimize this phenomenon, the suppository may be moistened with water before insertion. Number 4, potential interactions with the therapeutic agents. We know that gelatin is a protein that is obtained following partial acid hydrolysis to obtain gelatin type A, or following partial alkaline hydrolysis to obtain gelatin type B from animal collagen. The isoelectric point, we know that it is the pH at which the molecule has no charge. So the isoelectric point of type A gelatin is between 7 and 9, whereas the isoelectric point of type B gelatin is between 4.7 and 5.3 pH. Accordingly, the pH of the aqueous solutions of each type of gelatin will affect the ionization. Type A gelatin will act as a base if formulated at pH below 7, while type B gelatin will act as an acid if the pH is raised above 5.3, which is above the isoelectric point. As a result of this, a possibility arises for gelatin to interact with the therapeutic agents of opposite charge. This is follow the typical acid-base interaction. This will lower the solubility of the gelatin and may lead to precipitation. Therefore, it is very important to select the pH of the aqueous solution of the gelatin type carefully when formulating suppositories containing acidic or basic medicine. The other type of the water-miscible bases is the polyethylene glycols. These are water-miscible bases and are composed of polyethylene glycols with a molecular weight higher than 1000 grams per mole. There are a number of higher grades of polyethylene glycols. As the molecular weight increases for these bases, then the melting point of these bases increases as well. For example, the melting point of polyethylene glycol 1000 are in the range between 37 to 40 degrees centigrade, while the melting point of polyethylene glycol 8000 are in the range between 60 to 63 degrees centigrade. The melting point of polyethylene glycol suppository bases typically in the range of 40 degrees centigrade. This is achieved and controlled by using the appropriate mixtures of grade of this polymer. The higher melting point of these polymers are advantageous in the avoiding the need for storage under cold conditions. The melting point also has another advantages of controlling the mechanical properties of the polyethylene glycol based suppositories. In this scenario, the low molecular weight polyethylene glycols, example that base with molecular weight of 400, will act to reduce the brittle behavior of these suppository bases. In the rectum, these suppositories will not melt, but because of their hygroscopic properties, they will dissolve gradually in the rectal fluid. The rectal fluid is too small to allow for rapid dissolution. and therefore will enable drug dissolution to occur. This ability of the base to absorb moisture can cause patient discomfort. This is because of the extraction of water from the rectal mucosa into the suppository, causing patient to feel uncomfortable with the use of this suppository. This can be minimized by the inclusion of water at concentration of 20% or by moistening the suppository prior to insertion. Therefore, the suppositories prepared from polyethylene glycol bases require to be stored in moisture-resistant packaging. There are other two final concerns regarding the use of this base in the preparation of suppositories. These include, number one, the interaction between the drug and the polymer of the base. This causes the enhancement of the solubility of the therapeutic agent and subsequently affect the release of the drug from the formulation. Secondly, the solubility of the drug in this solid formulation will be affected by the storage conditions and the time, and this can result in crystal formation within the suppository. This, in turn, can affect the mechanical properties and the drug release from the suppository. The drawbacks of the use of polyethylene glycol bases in the formation of suppositories. Number one, hygroscopicity. Just like glycerogelatin base, polyethylene glycol bases can cause irritation because of the hygroscopic property. This can be overcome or reduced by the addition of water at 20% to the formulation of the suppository. It can be reduced as well by advising the patient to dip the preparation or the suppository in water before insertion. Number two, poor bioavailability of the medicaments. The good solvent property of the base can cause a retention of the drug in the base, and this subsequently cause a reduction in the therapeutic effect. Number three, incompatibilities. Polyethylene glycol bases are incompatible with some medicaments, such as bismuth salts, ecthamol, benzocaine, and phenol. And these bases also can reduce the activity of quaternary ammonium compounds and hydroxybenzoate. So it's not suitable to use these bases with these medicaments. Polyethylene glycol bases are also interact with some plastics, and this limits the choice for the container for the suppository. Number four, brittleness. Polyethylene glycol suppositories may be brittle. This can be avoided by pouring the base at the lowest temperature as possible. Also, this effect can be reduced by the addition of surface active agents or plasticizers. Product may undergo fracture on storage, especially if they contain water. This can be due to the high solubility of the base, which can lead to a supersaturated solution in water, and subsequently causing crystallization, which makes the mass of the base granular and brittle. Finally, crystal formation. Some medicaments may undergo crystal formation, particularly if they are partly in solution or suspension in the base. So, crystal formation can affect the product, the suppository product, to be brittle. The crystals can be irritant by itself, and because they are large, they take longer to dissolve, resulting in a delayed onset of action. The third subcategory of the suppository bases is the miscellaneous bases. These are a combination of fatty bases and water-soluble bases. Some of them are emulsion of the water in oil type. The mechanism of release of the active ingredient from such kind of bases will be a combination of the melting at body temperature with dissolving in the body fluid, such as rectal fluid. Example of such bases is polyoxyl 40-stearate, which acts as surfactant in commercial suppository preparation. Sometimes soap is used as suppositories, where soap acts as emulsifying agent. Example, soap glycerin suppositories. Suppository excipients or additives. The list of possible excipients is more limited for suppositories than for other dosage forms. Briefly, these can include surface active agents or surfactants, agents to reduce hygroscopicity, and agents to control the melting point of the base. Methods of preparation of suppository dosage form. The first method is by hand molding. This method is the oldest and the simplest method. It's used only when a few suppositories are to be prepared in cocoa butter base. This method has the advantage of avoiding necessity of heating the cocoa butter. In this method, a plastic-like mass is prepared by triturating the active ingredient with the cocoa butter. This mass is then formed into a ball and then rolled into a cylinder shape. The cylinder is then cut into an appropriate number of pieces, which are formed into a conical shape. This method requires practice and skills. The second method of preparing suppository dosage form is by compression molding. In this method, the mass prepared from mixing suppository base with the active ingredients is forced into a special compression mold. The capacity of the molds need to be determined, and this done by compressing a small amount of the base into the dies and weighing the finished suppositories. When active ingredients are to be added, it is very important to omit the portion of the suppository base. We're going to discuss this calculation later on. The other way of preparing suppository dosage form is by fusion molding. This method involves first melting the suppository base and then adding or dispersing or dissolving the active ingredients in the melted base. So in this case, we don't have a mass, we don't have a dough, but we have a melted mixture of the suppository base and the active ingredient. The mixture, which is liquid now, is removed from the heat. Of course, we need heating to dissolve the base. And then this mixture, as we said, removed from the heat and then poured into the mold. The mixture, after being congealed, the suppositories can be removed from the mold. This method can be used with all types of suppositories and must be used with some of them. How to calculate the mass of the base required to prepare suppository dosage form. To ensure that the correct volume of the base is used, a calculation is performed based on the displacement value. That's to say, the ratio of the weight of the drug to the weight of the base displaced by the drug. The displacement factor may be defined as the weight of the drug required to displace a unit weight of the base, usually theobromine oil base. Displacement values of various medicaments are given in the Pharmaceutical Codex. For example, the displacement value of cincocaine hydrochloride is 1.5 for cocoa butter. That means 1.5 gram of the active ingredient, which is cincocaine hydrochloride, can displace 1 gram of cocoa butter. And we know that solid can displace an equal volume of liquid. Although the displacement value is provided by the Pharmaceutical Codex, in practice, this value can be calculated as follows. Number 1, the average weight of the suppository mold is calculated using a blank or plain suppository base, and this is done by adding the molten base to the correct mold volume, allowed to cool, and then weigh them. Secondly, the weight of the drug needed for the total number of suppositories required to be prepared is calculated. Finally, suppositories that are prepared by adding the mass of the drug to the mass of suppository base, melting them, and then dispensing into the molds, the appropriate mold, of course. and then the weight of the cooled or congealed suppositories is then determined. Example: calculate the quantities required to make 10 theobroma oil suppositories using 2-gram mold. Each suppository contains 400 mg of zinc oxide. The displacement value of the zinc oxide equals 4.7. So first of all, we need to calculate the total weight of zinc oxide required to prepare the 10 suppositories. Secondly, we need to to calculate the weight of the base that would be required to prepare the unmedicated 10 suppositories before the addition of the active ingredient. And then determine the weight of the base that would be displaced by the medicament. So we determine the weight of the base that the zinc oxide will displace after adding it to the total base weight. Finally, calculate the weight of the base required to prepare the medicated suppositories. So in this case, we calculate the weight of the base after adding the zinc oxide. So first we start with the weight of zinc oxide. So the weight of zinc oxide required to prepare the 10 suppositories will be 400 mg times 10, and this gives 4,000 mg or 4 grams. The weight of the base required to prepare the unmedicated suppositories will be 2 grams. 2 grams. And this is from the from the 2 grams mold times 10, and this will give 20 grams. So theoretically we need 20 grams of the plain suppository base to prepare the 10 theobroma oil base. The displacement value of zinc oxide is given by the question to be 4.7, which means that 4.7 of zinc oxide will displace 1 gram of theobroma oil. That means 1 gram of zinc oxide will displace 1 over 4.7 grams of the theobroma oil. So we don't have 1 gram of zinc oxide in this case. We have 4 grams, and we calculated this in this step, in the first step. So 4 grams times 1 from here, divided by the displacement value, which is 4.7. This will give 0.85 grams. This means that 4 grams of zinc oxide will displace 0.85 grams of the base. Therefore, the weight of the base required to prepare the medicated suppositories will be 20 grams. Take away the displaced weight, which is 0.85, and this will give 19.15 grams. So we need to add 19.15 grams of the theobroma oil base to the 4 grams of zinc oxide, mixing them, and then use 2 grams mold to prepare the 10 theobroma oil base. To make it easier to calculate the amount of the base displaced by the active ingredient, we can simply divide the amount of the active ingredient by the displacement value. So for example, if we have 200 mg of a drug to prepare suppository, and the displacement value of this drug is 4, then 200 milligrams divided by 4, and this gives 50 grams. This means that 200 milligrams of the drug will displace 50 grams of the base in each mold. If we have a glycerogelatin base, which is water-soluble base, this base has a density which is 1.2 time greater than that of theobromo oil base. What we have mentioned before was all about theobromo oil. So if we have 1 gram suppository mold, this mold will produce 1 gram of theobromo oil suppository. But if we used glycerogelatin base, then this mold will produce 1.2 gram of the gelatin base suppository. This factor, which is 1.2, must be taken into account when calculating the displacement value of the medicine. In this example, you are asked to calculate the quantity required to prepare 6 glycerogelatin suppositories. Using 4 gram mold, each suppository should contain 100 milligram of aminophylline. The displacement value of the aminophylline is 1.3. So again, we follow the same steps. First, we need to calculate the weight of aminophylline required to prepare the 6 gelatin suppositories, and then we need to calculate the weight of the gelatin base that would be used to prepare the unmedicated suppositories. Then we need to determine the weight of the base that would be displaced by the aminophylline, and finally calculate the weight of the base required to prepare the medicated suppositories. So the total weight of aminophylline required to prepare the 6 suppositories will be 100 milligrams times 6, and this gives 600 milligrams or 0.6 grams. And then the weight of the base required to prepare the unmedicated suppositories, it would be 4 grams, because we use it's from here, from the 4 gram mold. So 4 grams times 6 suppositories. Because we are using glycerogelatin base, we need to multiply this by the factor, by the density of the base, and this gives a weight of 28.8 grams. The displacement value of aminophylline is given in the example, which is 1.3. We mentioned before that we can simply calculate the displacement value by dividing the amount of the medicine or the drug by the displacement value. So this will give 0.46 grams. This is the case of theobroma oil base. But we are not using this base. We are using the glycerogelatin base. So again, we need to multiply by the factor, which is 1.2. So we multiply this, the amount of the base that would be displaced by the theobroma oil. We multiply this by the factor of the glycerogelatin base. This gives 0.55 grams. So the weight of the base required, which in this case it is the gelatin base. The weight of the glycerogelatin base required to make the medicated. Now we are talking about the medicated suppositories. This would be this weight minus the weight that are displaced by the medicine, which is 0.55, and this gives 28.25. So we need to mix 28.25 grams of glycerogelatin base with 0.6 gram of the aminophylline to prepare 6 glycerogelatin suppositories. Sometimes the active ingredient is present in the suppository as percentage of weight per weight. In this case, the displacement value is not required in the calculation. This can be explained in this example. So what quantities are required to prepare 8 theobroma oil suppositories using 4 gram mold? Each suppository should contain 1% weight per weight of lignocaine hydrochloride. So you can notice that there is no amount or no concentration of drug. It's only the percentage of the active ingredient in the suppository, and the question doesn't mention the displacement value of lignocaine. So in this case, we need first to calculate the amount or the weight of the base required to prepare the unmedicated suppositories, and we need to calculate the weight of the active ingredient to prepare the 8 suppositories, and then we need to subtract the weight of the drug from the total weight of the suppositories to find the weight of the base. So the weight of the suppositories will be 8 times 4, because the question asked to prepare 8 suppositories using the 4 gram mold. This equals 32 grams. So the total weight of the suppositories is 32 grams. Then the weight of the active ingredient will be 1% weight per weight. That means 1% of the 32 grams. So 32 times 1 divided by 100 grams, that gives 0.32 grams. This is the weight of the lignocaine in the 8 suppositories. So the weight of the theobroma oil base will be 32, which is the total weight of the 8 suppositories. Take away 0.32 grams, which is the weight of the active ingredient, and that gives 31.68 grams. So we need to add 31.68 grams of theobroma oil base to 0.32 grams of the lignocaine, mix them, and then prepare 8 suppositories using 4 gram mold. In the previous example, we had a theobroma oil base. However, if we have glycerogelatin base, then we have to use the correction factor, which is 1.2. And we discuss why we have to multiply all the time with this correction factor. In this example, it asks to prepare 12 glycerogelatin suppositories. Each suppository should contain 0.5% weight per weight of lignocaine hydrochloride using 2 gram mold. So you can see there's no mentioning of the displacement value, and the active ingredient is present as a concentration, as a percentage of weight per weight. So to solve this example, we follow the same step. So we need first to calculate the total weight of the suppositories, and taking into account the higher density of the glycerogelatin base. And then we calculate the weight of the drug required by converting the percentage into concentration or weight. And then we need to subtract the weight of the drug from the total weight of the suppositories to get the final weight of the base required. So the weight of the suppositories will be 12, because in the question or in the example it asks to prepare 12 suppositories, times 2 because of the 2 grams mold here, and don't forget to by the correction factor, which is 1.2, because we are using glycerogelatin base. This gives 28.88 grams, which is the total weight of the suppositories. The weight of the drug is the concentration, the percentage, sorry, 0.5 times the total from here, times the total weight of the suppositories divided by 100 equals 0.144 grams or 144 milligrams. This is the amount or the weight of the active ingredient. The weight of the base required to prepare the medicated suppositories would be the total weight of the suppositories, take away the weight of the active ingredient, and this gives 28.66 grams. So we need to mix 28.66 gram of the glycerogelatin base, mix it with 144 milligrams of the active ingredient, and using 2 gram mold to prepare 12 glycerogelatin suppositories. That's it. Regarding the problems associated with formulation of suppositories, there's no need to repeat them because we already mentioned them with each category of the suppository dosage form, and we mentioned as well the solution for each problem. That's all about what you need to know about suppository dosage form, and thank you.